very happy afternoon to all the doctors who have joined for today's webinar program. So today I'll be speaking about tips and tricks to improve the success rates in IUI. So as a gynecologist, every one of us will definitely wondering why that in spite of doing a repeated IUI to our patients, the patients in spite of having all the parameters normal, still fail to conceive in an IUI treatment. So today's topic will address all those important points which are required for a successful IUI treatment and what could be probably going wrong in your treatment in the IUI cycles. So we all know that IUI is a simple, cost-effective, non-invasive and often a first line of fertility treatment which is offered by the gynecologist and is the most commonest performed fertility procedure across the world. So this procedure involves deposition of the sperms, that is the processed semen, into the upper uterine cavity close to the fallopian tubes in order to improve the chances of fertilization. So what are the factors affecting the success of an IUI treatment? So the first thing is the couple parameters. Whether you are selecting a proper couple for the IUI treatment. Are the couple the suitable candidate for IUI treatment? What is the duration of infertility in that couple? What is the cause of infertility? And whether the therapies which you are following, that is the protocols for IUI treatment from your end, whether they are correct, whether you are following the right protocol for controlled ovarian stimulation, whether a proper ultrasound monitoring has been done, whether the semen processing technique is apt, the timing of insemination and the luteal phase support. So all these therapies which are offered during an IUI treatment should be appropriate in order to maximize the success rates of IUI. So why could be your patient who is having repeated IUIs with you is probably failing? So the probable reason is one thing, the wrong selection of the couple. The couple were never a suitable candidate for an IUI treatment. So you are probably the patients who are actually a candidate for IVF has been wrongly selected for an IUI treatment. Wrong assessments of tube. So often the tubal assessments will happen through a HSG, that is the hysterosalpingography or a SSG treatment. So what happens? This SSG or HSG might just tell whether the tubes are patent or not, that is whether they are open or not, but it does not determine the functionality of the tubes. So if the tubes are having peritubal adhesions, if there are a lot of adhesions surrounding to the ovaries, uterus and also the tubes, then the functionality of the tube will get affected. So the tube might be open, but it is not functional to cause the sucking of the egg as soon as the ovulation happens and proper fertilization procedure which should happen in the tube. So there could be a wrong assessment of the tube and you might be following the incorrect stimulation protocol and monitoring through the ultrasound, and you might have wrongly selected a patient who is not having adequate ovarian reserve. This is something which has been overlooked by most clinicians or gynecologists. So the assessment of ovarian reserve is very important. So we get a lot of patients who actually have low AMH and very less number of eggs continue to do IUI treatments for a long time under gynecologists, not even realizing that they have a decreased ovarian reserve. So such patients will always be ideal candidates for an IVF treatment. So make sure that the AMH levels or the antral follicular count is adequate, then only the patient will be suitable for an IUI treatment. The triggering, where we give HCG triggers or an agonist trigger for the purpose of ovulation, it might be given at a wrong time or the trigger option itself might not be correct. Then comes to the inefficient semen preparation. So you might be having many patients who are having normal or near normal semen parameters, and in spite of doing the semen processing and transferring the sperms into the uterine cavity, still the patient will be unable to conceive in spite of having a patent tube and also good ovulation and all on time. So what happens is that even if you are having a normal semen parameters, if the processing of the semen sample is not proper, like you are centrifuging the semen sample so too much, so it can actually increase the DNA fragmentation of the sperms, or it could damage the sperms to such an extent that it might fail to have a proper implantation and subsequent pregnancy. So don't be under the assumption that if you are taking a sperm concentrated and transferring inside the urine, no matter what is the semen processing technique, it will yield in success. So proper semen processing technique is most crucial for a good IUI success. Then in the timing of the insemination. So most gynecologists just give the trigger and call the patient 36, 38, 40 hours later. So the patient might have prematurely ovulated by her body's mechanisms, and you might be doing the insemination much after the death of the egg. Like it could be 12-24 hours post ovulation, which can actually lead to demise of the oocyte, which can, again, fertilization cannot happen. So it's very important that the IUI is performed soon after ovulation so that fertilization chances are improved. Then another crucial important thing about an IUI is whenever we are doing an ovulation induction or a stimulation, luteal phase support is very, very important, because most of these patients who are undergoing this kind of treatment will have either a follicular phase defect or a luteal phase defect. So it's important to stimulate these patients and also supplement them with a proper luteal phase correction or support, so that the IUI success rates also improve. And we are only concentrating on ovulation, a patent tube or a semen parameters. So we fail to identify other comorbidities which can lead to infertility, be it hypothyroidism or a hyperprolactinemia or uncorrected diabetic status and all. So it's important that all these comorbidities are appropriately identified and treated before the patient opts for an IUI treatment. So coming to the success rates of IUI, what determines the best success rates for IUI? So how can you maximize the success rates of IUI in your clinic? So the first thing is you choose what kind of IUI you want to do, whether you want to go for a natural cycle or you will give just oral drugs for ovarian stimulation and perform IUI, or you can combine oral ovulogens with gonadotropins and then perform an IUI, or go with just gonadotropin and IUI. So you can see here the success rates of an IUI is maximum when the doctor is using the gonadotropin. So that is the reason, if you want to maximize, definitely go for a gonadotropin along with IUI, where the success rates of IUI can reach as high as 18%. In natural cycle, it's about 13%. Oral ovulogens up to 14%, and then a combination of drugs up to 15%. So one thing is important that you should also keep in mind whether you will be able to monitor the patient properly through an ultrasound whenever you are advising the patient to take a gonadotropin therapy. So yes, my choice would be opt for a gonadotropin, do a proper ultrasound monitor in order to maximize the success rates of IUI. So what are the success rates when it comes to the couple characters? Who are the ideal candidate for an IUI treatment? So the first comes is the maternal age. So we know that with advancing maternal age, there is fewer oocytes which you can obtain per cycle. As the age of the woman increases, especially after the age of 35, the chances of aneuploidy rates increases. That is, the probability of abnormality of the eggs increases, which can actually lead to poor quality of eggs, lower implantation rates, increased chances of miscarriages due to chromosomal errors. So it's important that your patient is of a lower age, that is ideally less than 35 years of age. Now you can see that this is a study which was published where according to the age, they have determined the success rates in various studies. So when the patient's age is, the maternal age is less than 30, you can expect a success rates of 15% per cycle. And as the maternal age increases, like between 30 to 35, 14% success rates, between 36 to 39, about 7.8% success rates. And when the maternal age crosses 40, it's hardly 2%, owing to a lot of aneuploidy in the oocytes which are ovulated. That is the reason you want a best success rates in IUI. Always choose the patient who is less than 35 years of age, so that the IUI's success rates can be maximized. And as the maternal age keeps increasing, it's better we get more aggressive and go for an IVF treatment. Then when it comes to the duration of infertility, try to ascertain how long the patient, the couple have been infertile. Suppose if the patient has been infertile for less than 4 years, then definitely those are the ideal candidates for IUI treatment. Provided the other parameters are also suitable for IUI, you can expect a success rates of up to 15%. And if the duration of infertility is more than 4 years, then the success rates is hardly 6%. So we have to understand, as the duration of infertility increases, if the patient is having like primary infertility or secondary infertility, it means that the patient is having some serious issues at the levels of gametes, be it at the level of fertilization or implantation, which has led to long-standing infertility. Hence, it is best to choose a couple who are married for less than 4 years to get the best success rates of IUI. Then coming to the male factor, how should be the male parameters when we are selecting the couple for an IUI treatment? Ideally, the man should be of less than 45 years and he should have a minimum semen count. Like if you do a post-wash semen analysis, or first a pre-wash semen analysis, the count should be at least more than or equal to 10 million. And you know that many IVF centers, when you go for a semen test, also give this post-wash analysis as well. So if the man's post-wash analysis is more than 5 million of total motile sperm count, then yes, they are the ideal candidates for IUI treatment. So if you go in various studies, there is no consensus that what should be the ideal cutoff for an IUI treatment, whether it is 10 million, 11 million, 12 million and all. So different studies have determined different success rates. So generally when the pre-wash count is more than 10 million, you can take the patient for IUI, provided the post-wash total motile sperm count is coming to more than 5 million. Of course, when there is borderline semen count also, there could be success in IUI, but the success rates would be less. That is the reason if you want the highest success rates in IUI, then better opt for these kind of semen parameters. The DNA fragmentation index should be ideally less than 15%, and the sperm survival rate at the end of 24 hours should be at least 70%. And the sperm shape, that is the morphology of the sperm, should be always equal or more than 4% to get the best success rates in IUI. That is the reason teratodisospermic patients, like patients who are having a semen morphology of 2%, 3%, they are not the ideal candidates for IUI treatment. Although in a young patient who is newly married and who is undergoing IUI treatment, they might still conceive in an IUI treatment. So there's no consensus that this is the cutoff, this is the cutoff. The best success rates can be achieved when the morphology is very good, the DNA fragmentation index is less than 15%, and the sperm survival rate is more than 70%. So when you are choosing a patient for an IUI treatment, if you want to evaluate the man properly, so get this pre-wash analysis and post-wash analysis from a good fertility center to determine whether your couple or a patient is suitable for IUI treatment. So often many of us wonder that the husband is having the perfect semen analysis of good count, motility and morphology, but why still the patient is not able to conceive? So one thing it's important to understand that a normal semen analysis does not mean a intact DNA of the sperm. So we know that for a viable pregnancy, for a proper fertilization, implantation and a successful live birth, it takes a good intact sperm DNA in order to get good success rates. So your semen analysis is only assessing the count, motility and the morphology of the semen, but it is not evaluate whether the sperm is having a normal integrity of the DNA. So that is the reason this sperm DNA fragmentation index has come into picture to determine whether your patient, in spite of having a normal semen analysis, is suitable for an IUI treatment or not. So you can see in this graph, almost about 36 patients of the men who show normal semen analysis actually have an elevated DNA fragmentation index. So there are different assays to do a semen DNA fragmentation index. So among this, different assays calculate different cutoffs, but generally a semen DNA fragmentation index of less than 15% is considered normal, 15 to 25 is considered equivocal, and something beyond 25 or 30 is considered abnormal. So if you take normal semen analysis patients, almost about 36% of normal semen analysis men do have this elevated DNA fragmentation index, indicating that that could be the reason of their infertility, and those are not the ideal candidates for IUI treatment. So does that mean that all men should undergo, even if the semen analysis is normal, should undergo a routine DNA fragmentation index test? No, the current consensus tells that there is insufficient evidence to recommend these tests on a routine basis. However, if your patient is having the following criteria, like they are the patients who have to undergo the DNA fragmentation index. That is, if the man's age is more than 40, he gives history of long-standing smoking, there is history of varicocele on the scrotal scans, patient is already having oligoasthenoteratozoospermia, patient is diabetic, the patient who has had repeated treatment failures, be it with ovulation induction, timed intercourse, or IUIs, or patients with unexplained infertility where everything seems to be normal, but you still suspect that there could be a raised DNA fragmentation index, and patients with recurrent pregnancy loss. So again, these are the candidates. These are the men who have to undergo sperm DNA fragmentation index in spite of having a normal analysis. So why is this SDF so important? So you can see this graph. This was a study which was published in Human Reproduction. So you can see that patients who are undergoing IUI, in men who had a normal sperm DNA fragmentation index, the live birth rates following an IUI treatment was about 19%, whereas the patients who underwent IUI with elevated DNA fragmentation index had a live birth of just 1.5%. So you can understand that it is such a waste of time, energy, and money doing a IUI treatment when men are having an elevated DNA fragmentation index. So what is the best treatment for these men who are having elevated DNA fragmentation index? This was a study which compared IVF and 𝐓𝐫𝐢𝐜𝐤𝐬 outcome. So you can see that almost 42% of men who had elevated DNA fragmentation index had a successful live birth when compared to 26% in an IVF treatment. So that is the reason patients with elevated DNA fragmentation index, 𝐓𝐫𝐢𝐜 is the treatment of choice in order to get the best live births. So I finished the couple parameters as far as the success rates of IUI are concerned. So we will always choose a woman who is less than 35 years with duration of infertility of less than 4 years, and a man who is aged less than 40 with a normal DNA fragmentation index of less than 15%, with a sperm survival rate of more than 70%, whose total motile sperm count is more than 5 million. Then when come to the indications, what are the reasons why you are performing an IUI? So based on the indication for IUI, that is the cause of infertility, again determines what is your success rates in IUI. So if you are doing IUI for an anovulatory infertility, or patients with azoospermia who are undergoing IUI with donor sperms, or the patients who are suffering from cervical factor infertility, no doubt these patients have the best outcome in the IUI treatment. This is followed by good outcome in an unexplained infertility. And the patients who are having poor outcome is all those patients who are more than 35 years, patients with stage 3-4 endometriosis, patients with immunological factors, or patients with poor total motile sperm count after the semen washing. So the IUI success rates as far as the pregnancy rates, as far as the etiology of the infertility is concerned, the best success rates, as I said, is with anovulatory and patients with azoospermia who are undergoing donor insemination, followed by 15% success rates in unexplained infertility, and the success rates are least in endometriotic patients where the IUI success rates can be 6%, and this is true only for patients with mild to minimal to mild endometriosis and not for moderate and severe. So then the onus lies on us to give the best success rates in IUI based on the therapies which we are offering to the patient. Now I have selected a patient who is ideal for a IUI treatment going by their personal characters, be it the age, be it their semen parameters, the ovarian reserve, the patent tubes, everything. Then comes what I am offering to the patient in order to increase the success rates. The first step in an IUI treatment is ovulation induction or controlled ovarian stimulation. So why I want to do a controlled ovarian stimulation in a patient who is already ovulating? So one thing, I want to increase the number of oocytes which are available for fertilization in order to increase the success rates of IUI, because more the oocytes are available for fertilization, and hence more the chance of implantation and a successful pregnancy. And when there are more oocytes, the estrogen levels will also be high, so it can overcome the subtle follicular phase or a luteal phase defects which were there, and all these hormonal deficiencies do get corrected, and there is an increased fertilization window available for the gametes, so that we can increase the chances of fertilization and the successful IUI. So does that mean that I will increase the number as much as possible? No. There is an ideal scenario where we should have a number of oocytes and all. So the rationale is simple. It is to increase the oocytes available, increase the chances of fertilization and implantation. But at the same time, we should make sure that it is safe for the patient also. So ideally, we should get 2 to 3 follicles only for IUI in order to prevent ovarian hyperstimulation and higher order pregnancies. So we should ideally get 2 to 3 follicles of 18 to 20 mm, with each follicle producing an estrogen level of an average of 200 picogram per ml. And this endometrium should be showing a good trilaminar with good vascularity, and ideally the patient should respond in such a way that we are able to complete the IUI procedure between day 13 to day 16 of cycle. At the same time, in case if the patient has overtly responded and you have more number of intermediate follicles, or if the follicles are more than 4 of higher order, then it's better to cancel the IUI in order to prevent OHSS and also higher order pregnancies. Then what should be the ideal number in order to get the best outcome in the IUI? So you can see that with 1 follicle, the success rate is about 6%. It increases to 14% with 2 and increases to 16% with 3 follicles. And thereafter you can see as the number increases to 4 follicles, there is actually a drop in the IUI success rates. This is because more and more estrogen levels can again displace your implantation window as well. The endometrial receptivity can get advanced, which can lead to failures and all. So that is the reason ideally we should get 2 to 3 follicles, mature follicles, in order to get the best success rates in IUI. Then whether use of drugs like GnRH antagonist is going to help us in improving the IUI success rates. Yes, there are very selective patients who, if we use the antagonist, might improve their success rates. Like patients who are having premature surge, like you are calling the patient 36 hours later and you see there is already a premature ovulation. There is already an ovulation happening like at around 16-17 mm follicle even before you could administer the trigger and all. Or patients who are having persistently elevated LH levels beyond the threshold of LH, that is beyond the ceiling levels. So that can actually lead to atresia of the follicles and also poor quality of the oocytes. So in order to overcome this tonically elevated LH levels, you can administer Antax in order to keep the LH levels in the window of LH, that is between the threshold and the ceiling. And suppose if the patient has overtly responded, you have to convert it into an IVF cycle, you can go for use of antagonist. And suppose if you want to postpone the IUI by a day or so, because the IUI is falling on a weekend and all, you can go for use of antagonist. Ideally, the antagonist has to be started when the dominant follicles reaches 14 mm and should be continued till we plan the trigger. Then coming to the pregnancy rates by different ovulation induction. So this I already discussed. Couples who are using gonadotropins for controlled ovarian stimulation have the highest success rates in IUI treatment. Then coming to the trigger option, which is an ideal trigger in order to get best success rates, whether you are using a urinary HCG of 5,000, 10,000, or you are going for a recombinant HCG in the form of orbital 250, either way the success rates will remain the same. So you can go for either of these triggers. Alternatively, you can also go for an agonist trigger if you want to keep the cost low, or if you are feeling that there are too many intermediate follicles to avoid OHSS and all. Then timing of HCG. So there are different people who just follow some trigger at 16 mm, some trigger at 20-22 mm of the follicle. So what is the ideal timing for HCG trigger in order to schedule for IUI post ovulation? So this is the main point of success of IUI. Ideally, you should trigger the patient when the follicle has reached a mean diameter of 17 to 18 mm with a volume of 3 to 7 cc. You should also check the peripheral vascularity of the follicle, and if you are able to see 3/4 of the vascularity surrounding the follicular walls, then the follicle is deemed to be a mature follicle. You can alternatively measure PSP, and if it is more than 10 centimeters per second, you can see a good perifollicular resistance of less than 0.4 or 0.48. And at the same time, it is also showing a good endometrium of 8 mm and above with good trilaminar pattern and good vascularity. Then that is the time you have to plan your surrogate LH in order to make the patient ovulate. Post triggering, you should call the patient about 36 to 38 hours later, unless you are anticipating a premature rupture because of more number of follicles which are available, which can cause premature LH surge. So when you do the scan, you can see a coccygeal cyst, that is a corpus luteal cyst, which is seen in about 90% of the patients. There is Sometimes just a shrinkage of the follicles, which is again a sign of ovulation. There could be a presence of a disappearance of the follicle, that is again seen in about 90% of patients. Presence of fluid in the POD, appearance of an internal echo inside the follicle, that is signs of hemorrhage, is again a sign of ovulation. If you are not able to correctly determine whether ovulation has happened or not, you can go for a serum progesterone measurement, and if it is more than 3 nanogram per ml, it is a sign of ovulation. So I triggered the patient, I called and checked for ovulation, and after confirming the ovulation, we have to plan for an IUI treatment. So what is the role of ultrasound? So this is very much crucial for a proper ultrasound monitoring so that a proper timing of the trigger is done. So first thing, whenever you are inducing the patient for an IUI, the first thing is the patient should be called for a second or third day of scan. Rule out presence of endometriosis, fibroids, endometrial polyps, or simple functional cysts in the ovary. And only if these kind of cysts are ruled out, the patient should be started on ovulation induction or a controlled ovarian stimulation. And as you do this follicular monitoring, it's important that you identify a mature follicle before the patient is triggered for ovulation. So as described, the follicle should be at least 18 millimeter in size with 3/4 of peripheral vascular flow, with cumulus suphorus and a volume of the follicle about 3 to 7 cc. At the same time, a receptive endometrium of about 8 to 14 mm, which is triple line in pattern, which shows good zone 3 or 4 vascularity. And if you do a uterine artery Dopplers, the RI should be less than 0.8 and PI should be less than 3 for a good implantation chances. Then the onus lies on your andrologist to give a good semen preparation. So ideally, the andrologist should assess the semen analysis properly, decide whether the patient is a candidate for a swim-up technique of semen processing or a density gradient. So this, as I said, once the patient gives the sample, we have to check for pre-wash count, motility and all. If the pre-wash count motility is near normal, then the patient can opt for a swim-up method of semen preparation. And if there is oligoasthenoteratome, then it is better to go for density gradient of preparation. Now, the environment where this kind of semen processing happens is crucial again for a proper sperm survival in order to maintain good DNA integrity of the sperm so that best success rates can be achieved. So ideally, the semen processing should be done in a good andrology lab, which has a good maintenance of equipment. The processing should happen in a laminar airflow with the centrifuge machine should be a spermifuge, which is a temperature controlled centrifuge machine where the temperature does not dip there and it is maintained at around 37 degrees Celsius. Proper incubators to maintain the temperature of the sperms, DG blocks, refrigerator to store the sperm wash media and all should be done. It should be a contamination-free environment with views of good consumables for handling of human gametes. So all these things are very crucial for a IUI success rates. Otherwise, you will be taking a normal sample and actually destroying it in the lab and then inseminated inside the female partners. Definitely, we cannot expect any success rates. So how should be the semen parameters? As I discussed, the initial total sperm count should be at least more than 10 million. And after processing, it should be more than 5 million of total motile sperm count. The post-wash minimum should be more than 1 million, that is the total motile sperm count, and ideally if it is 5 million, we can expect best success rates, and 24-hour sperm survival rate should be more than 70%. So what is the optimum number of motile sperms should reach the fallopian tubes? It is somewhere between 1 to 5 million. The higher the count, the better the success rates. And how much should be the inseminated volume? We know that uterine capacity is about 0.3 to 0.5 ml, and you should take an active concentrate of 0.3 to 0.5 ml of the sperm concentrate into the sperm wash media and inject it into the upper uterine cavity. So the loading to insemination is again crucial for the sperm survival and the success rates of IUI. If there is a time lapse of more than 20 minutes by the end between the end of processing to the insemination, then definitely there is a significant loss of motile sperms in this time and a compromised IUI result. So ideally, the semen should be inseminated into the uterine cavity as soon as the sperm processing is completed. The timing of insemination, as I said, this is very crucial, and this is one of the most common reasons why IUIs are not successful. Yes, one is the semen technique, the other one is the timing of insemination. So we have to understand the egg can survive only for about 12 to 24 hours. And if you are doing IUI beyond this time, definitely there won't be an active egg to get fertilized. So you should ideally plan your IUI about 36 to 38 hours post trigger, call the patient for a confirmatory scan of ovulation, and IUI should be performed soon after ovulation. And if you're planning double inseminations, like you anticipate more number of eggs are there, you are anticipating premature ovulation and all, you can plan your IUI somewhere at, some people do at 24, 36 hours, 14 and 36 hours. Or some people do the IUI at 36 hours, and if there is no ovulation, repeat the IUI 12 hours later. So whether to go for a single insemination or double insemination, so according to the literature, there is no difference between the single and double inseminations. But of course, there are a selective set of patients who actually benefit from double inseminations. So these are patients who are having multiple number of eggs in the cohort, where there is different time of ovulation. Then yes, double insemination might actually help these patients. So single insemination usually misses these prematurely ovulated follicles. So that is the reason, in order to make sure that there is a semen load when there is premature ovulation, the double inseminations are timed at 24, 36 hours or 14 and 36 hours accordingly. So if you are planning a single insemination, call the patient 36 hours later, confirm ovulation, and then do the insemination. If you are doing a double insemination, you can do it at 14 and 36 hours or 24 and 36 hours, or do a single insemination at 36 hours, and only if there is no ovulation, you can repeat the IUI 12 hours later. So we understood like how an ideal ultrasound monitoring or a stimulation for IUI should be. But when to stop? So this is also equally important, because otherwise unnecessary the patient might land up with OHSs or higher order pregnancies. So if you get more than 4 follicles, 4 mature follicles, or you have multiple intermediate follicles, or if your estrogen level is more than 1500, it's best to defer or cancel the IUI. So how long you can actually try for an IUI treatment? So as I described till now, so you are going by these ideal circumstances of choosing the patient, seeing their cause of infertility, duration of infertility. You are offering the best therapies as far as the controlled ovarian stimulation is concerned. Ovarian stimulation monitoring you have done, you have timed the IUI, you have given a proper trigger, and you have called the patient post ovulation, did a proper semen processing and inseminated. So when you're doing in this kind of ideal scenarios, you can try up to about 3 to 4 cycles of IUI. So there are many studies which try to determine when the most patients will conceive in an IUI. So if a patient is a suitable candidate for IUI, about 71% of conceptions happen in the first 2 cycles of IUI, provided the couple are an ideal candidate for IUI. And about 85% of the IUI pregnancies happen in their first 4 attempts itself. And if the patient is unable to conceive at the end of 4 cycles, then it is very unlikely that they will be able to conceive in the 5th or 6th cycle. So it is best to change the treatment plan and reassess the patient and probably suggest them for an IVF-ICSI treatment. And when to offer IVF, if you have already failed 3 to 4 cycles of IUI, the patient is having an advanced maternal age, the father's age is more than 40 years, there's a long standing duration of infertility, the patient is having a low reserve, the patient's semen parameters are not up to the mark, there is bilateral or unilateral tubal blocks, then the patient should opt for an IVF treatment. Then coming to the technique of IUI, so one thing, this should be done in an aseptic precautions with full bladder in order to straighten the uterocervical length, and a transvaginal scan on the day of IUI should be done in order to confirm ovulation. Use non-powdered gloves, and transfer about 0.5 to 0.3 to 0.5 ml of a semen concentrate into the upper uterine cavity beyond the internal os. And while you're doing this, you should use a cuspo speculum, use a proper documentation, obtain consents before you do a IUI treatment. Slow insemination has to be done, and ideally the patient should rest for about 15 minutes after the insemination. And the timing of insemination between the semen collection and the insemination, the time gap should not exceed more than 90 minutes. So the best is to do IUI under ultrasound guidance so that you can see where your catheter is going in order to ensure an atraumatic transfer. So what type of catheter you are using, whether you are using a soft catheter or soft catheter or less pliable catheters, it does not make any difference as far as the IUI success rates are concerned. The ideal thing is that the patient should do an IUI in an atraumatic fashion under ultrasound guidance, so there is no difference in the success rates. Bed rest of over 10 to 15 minutes post insemination is recommended for the best success rates. And as I said, all these patients who are undergoing an ovarian stimulation do have a follicular or a luteal phase defect, and hence it's important that these follicular phase defects are overcome by ovulation induction or a controlled ovarian stimulation. At the same time, in order to overcome luteal phase defect, the patient should be supplemented with appropriate luteal phase to get the best success rates. So what luteal phase? Usually one progesterone supplementation would be ideal for a better success rates. Coming to the complications of IUI, it will happen only if the semen processing is not appropriate, which can actually lead to infection, pain, and pelvic inflammatory disease. And if you have not used the right controlled ovarian stimulation protocol and ultrasound monitoring, then there could be a chances of ovarian hyperstimulation syndrome and multiple order pregnancies. So when you're performing an IUI and controlled ovarian stimulation, it's important that you prevent OHSS and higher order pregnancies. So always go for mild stimulation, not more than 2 to 3 follicles. And if you are doing this with a polycystic ovarian patient where there is a chance of hyper response, probably consider doing an ovarian drilling for a controlled response. You can combine oral ovulogens or gonadotropins with metformins in order to prevent OHSS, and avoid giving an HCG trigger to prevent OHSS. Adding antagonist, cancellation of cycles, and gabapentin will definitely help to prevent this OHSS. So coming to the take-home message, IUI success rates are best when the maternal age is less than 30, when gonadotropin stimulation is used, when the duration of infertility is less than 4 years, when you are doing IUIs for an anovulation or an unexplained infertility or an azoospermia where donor inseminations are done. Proper tubal assessment is important. The ideal way of doing it is through a laparoscopic assessment. The patient should have adequate reserves, that is the AMH and antral follicular count should be normal. You should be able to identify her comorbidities and control and treat all those comorbidities, be it hypothyroidism, hyperprolactinemia, or diabetic status before proceeding into IUI. The semen processing should be done by a well-trained technician in an appropriate controlled environment. And best is not to impose any abstinence on the couple, which will actually decrease the DNA fragmentation index of the semen. The post-wash semen count should be more than 5 million, that is total motile sperm count, with normal morphology. Easy and atraumatic transfer soon after ovulation is ideal, and a good luteal phase support. So selection of a candidate is most important step in an IUI success. The clinician should know whom to select and when to stop, and when actually to refer the patients to a higher center for an IVF 𝐓𝐫𝐢𝐜 management. Good ultrasound monitoring, especially by the fertility specialist or gynecologist herself, is very crucial because we cannot rely on the radiologist measurements for us to decide our triggering options and all. Good luteal phase support, meticulous documentation, and good counseling are key for IUI success. Thank you.
So happy afternoon, everyone. My topic is on the evaluation of the male infertility. I'll be talking basics about the male infertility and how to evaluate the male infertility. So let me start with this quote. So this is very important throughout the session. Overall cause of male infertility, like 20 to 30% of the males, okay, it means 20 to 30% of the causes are due to the males, whereas 30 to 40% causes are due to females. So males are mainly due to the oligospermia and azoospermia and teratospermia also, whereas in females It is mainly due to this anovulatories as well as the tubal factors in both males and female. So 10 to 40% of the contribution are from both males and females, whereas 10 to 20%, again 10 to 20% are unexplained. So both will be normal. We don't know the reasons. So now coming on to this is a very important slide where I have compared all the manuals. If you see here, morphology of the sperm. See this morphology of the sperm in 1980, it was 80%. 80% sperms were normal, whereas it has decreased. When you come to 2010, only 4% sperms are normal. And now also in 6th edition, current edition 2021, 4% sperms are normal. Now see the second parameter, vitality. Vitality means live sperms. This live sperms in 1999, 75% sperms were normal. Okay, more than 75% were normal. Whereas in 5th edition, 58% were normal. And in 6th edition, 54% means the vitality, the live sperms are decreasing and the dead sperms are increasing. This is one of the reasons. Okay, and third point to remember here, you can see here. So I told about morphology. So morphology is decreasing. Okay, then I told about the vitality, the live sperms. So live sperms, it was more than 75%, and in 5th edition it was 58% live sperms, and in current edition, which is released in 2021, only 54% are live sperms. Means dead sperms are increasing, live sperms are decreasing. So finally coming to the volume. So volume was more than 2 ml, more than 2 ml. In 1987, it was up to 1999, it was more than 2 ml. In 5th edition, 2010, it was 1.5 ml. Again, the normal volume has decreased to 1.4. So with this, what we can conclude is that the male infertility is increasing. Okay, whereas the proper treatment is very, very essential for the male infertility, and the male has to be evaluated similar to the female. Now, the main causes of the male infertility are, first one, there I have listed under these 3 headings: one, pre-testicular cause, testicular cause, and post-testicular cause. Now, coming on this pre-testicular cause, so pre-testicular causes, it is very rare. Okay, and it may be if there is any major problem in the central nervous system, like the hypothalamus and in the pituitary. So this pre-testicular cause will fail. Now coming on to this, the major reason for this pre-testicular cause is GnRH deficiency, 𝐜𝐫𝐼𝐻 syndrome. So 𝐜𝐫𝐼𝐻 syndrome is nothing but where this GnRH neurons won't get into this the particular organ. From nasal placode, it won't go to the central nervous system. So where there is the pituitary gland as well as hypothalamus won't secrete any hormones. And other pre-testicular causes like acquired causes are like pituitary tumors or hypothalamic tumors or cysts, head trauma, and radiation to the base of the skull, and hyperprolactinemia, and some drugs like corticosteroids. So these can cause the pre-testicular causes, and this comes under acquired causes. Now, these pre-testicular causes can be treated by the hormonal supplementation. Coming on to these testicular causes are 30 to 40%, and these testicular causes can be chromosomal or acquired. So chromosomal can be like Klinefelter syndrome and Y chromosome microdeletion. And acquired causes can be cryptorchidism, varicocele, viral orchitis, for example, mumps, radiation, and trauma. So these are the testicular causes. Means the causes are in the testes. Now, coming on to this, these testicular causes. Whenever there is testicular causes, the patient usually walk into the IVF centers, and this can be treated, and it's mostly is sometimes it is irreversible. Most of the times we can treat to some extent. And post-testicular causes. So post-testicular causes, it's 10 to 20%. So 10 to 20%, it can be due to this congenital, congenital bilateral absence of vas difference, and cartilaginous syndrome, it is an autosomal recessive genetic disorder where there is a problem in the cilia. And acquired infection, there can be acquired infection like TB, gonorrhea, chlamydia, and surgical, whenever there is any surgical problem, vas difference, if it is injured during the surgery, and retrograde ejaculation. So these are all post-testicular causes. Usually this can be corrected. Okay, and infrequent vaginal intercourse or sexual dysfunction. This can be psychotic disorder, like they are drug-induced problem. This also can be corrected. And see, in one word, if I want to say, mostly treated with microsurgery or some medicines are available for this problem. This can be treated. Now, coming on to this most common cause, 60 to 80% of the people who walk into our clinic, both will be normal. There won't be any major problems. Okay, but this comes under like idiopathy, and they are now 90% of the people who are having idiopathic causes, they will consider ART. Okay, and some other risk factors like any severe diseases or any chronic diseases, okay, can cause this infertility. So this is general about the causes of the infertility. So now coming on to this, like usually when patient walks to the clinic, we usually tell we see for the female factors. Nowadays the study shows that even the paternal factors are very important to be noticed, because sperm chromosome abnormalities are common nowadays. Okay, for example, teratospermia. I told, out of, if you count 100 sperms, only 4 sperm will be normal in the normal patients. Okay, whereas a person who is having a real infertility problem, okay, more than 4%, like for example, hardly 1 or 2% will be normal. Nowadays, the patient who are after post-COVID, the patient who are walking into the infertility center, okay, we get hardly 1% sperms normal. Okay, now you see adverse fetal outcomes. See, if a person age is increased, if a male age is increased, a female we keep as a cutoff age 35 years. Male we keep it at 40 years as a cutoff years. So above 40 years, the sperm aneuploidies are more common. Okay, so this can be an adverse fetal outcome if we inject the sperm above 40 years. Means a male partner who is having above 40 years, we inject the sperm. So these are the main problems, like trisomy 21, craniostenosis can happen, achondroplasia can happen. So all these problems are more common. Now let us enter into our real topic. Now, if a patient is unable to conceive for 12 months of unprotected sex, so what they will do, they usually walk into the infertility clinic. So here I'm going to deal only with the male. Okay. Now, once they walk into the infertility fertility center, okay. Now, these 4. The protocol is like, if you read any book, it will give under these 4 headings. You have to evaluate the male patient. Okay. Firstly, you have to take the history of the patient. So history of smoking is very, very important, because the sperm count decreases. Okay, the count decreases rarely, whereas when a person is smoking, the sperm count is normal, whereas the motility is decreased. He will be having astenospermia. All this terminology I'll just be discussing in the upcoming slide. And occupational history is also very, very important. Okay, whether the person is working in the glass factory or whether he has done, he's doing daily a long journey for more than 50 kilometers, okay, or whether he is wearing a tight scrotal support, which can hinder the sperm function, okay. Now, sexual history, like this sexual history is also very important to know. Now, coming on to this, sexually transmitted disease, these things we have to rule out in the initial phase only. And history of surgery, okay, during childhood days, whether he has undergone any surgery for procreatism or varicose vein repair, whether he has undergone any varicose vein repair, these things has to be taken. And even drug history, like whether he is having any beta blockers or any steroids, and chronic illness can be a contributory factor. For example, diabetes. Sometimes diabetes, for people, they will be having some erectile dysfunction. The sperm parameter, it can damage the chromosomes. And family history also very, very important to be taken. Okay, so first is history taking. Then nowadays the studies are in progress, like electromagnetic waves from the mobile phones. Okay, the studies are going on. They have not proven it. So for first phase, they have proven it that the mobile phones are affecting the sperm. Okay, sperm motility. Okay, and it is causing the teratogen sperm. They have done a first phase study. Now there is a second phase study, like what should be the radiation to affect the sperm quality, okay, or I can say the semen quality. So nowadays they are doing this study. So the first thing is history taking is very, very important. This can be taken by the counselor, okay. Now, second one is physical examination. The physical examination of the male patient is also equally important. So first physical exam, first what we have to do is that, okay, you should assess the secondary sexual characteristics, where you should know whether the secondary sexual organs are grown properly. Now, then you have to examine the testicles. So a male doctor and a urologist, they have to examine the testicles. You should see whether the testis is in the scrotum or not. Whether the testis is small, you have to assess the size of the testis. Okay, retractile testis, whether the testis is in the normal position or in the upper part of the scrotum. Okay, abnormal, testicular masses, you should feel it with a clinical examination. And scrotal skin has to be evaluated properly to see whether there is any genital warts are present. Okay, now second one, check the epididymis. This is very, very important because the testis produces the sperm will come to the epididymis and it gets matured there. Okay, so how to evaluate the epididymis? This is general overview I'm giving. In depth you can go and read the infertility books and you will get in-depth knowledge. This is just a summary of one book I'm giving this. Okay, so you should see whether there is swelling of the epididymis, whether there is any inflammation, okay, or any infection. The epididymis can make the epididymis soft and tender. The patient can feel the pain when we touch the epididymis. This is the second thing you have to do. The third thing, you have to check the varicocele. This is very, very important nowadays to check the varicocele. There are different grades of varicocele. So it can be easily seen, in the naked eye. It can be easily seen. So you can see you can see this male, you can see the image where he's having the right varicocele, grade 3. Okay. Now, fourth one, examination of the penis. So examination of the penis is also important because you should check the opening of the penis. Okay, very important. And you should see whether the that developmentally the penis, it is separate, it will fuse later. You should see for hypospadiasis or epispadiasis, you should see whether there is opening on the above the penis or deep below the penis. You should check it properly. And very, very important to know, you should see whether there is any discharge in the tip of the penis. And it can be due to any urinary tract infection or any infection of the penis. There will be discharge in the tip of the penis. Now, So once you are done with the physical examination, so I have given an overview of the physical examination. You have to go for the tests. Okay, these are the 4 tests we usually do in the IVF lab. Okay, no, not in the IVF lab. This 4 tests is commonly recommended for the male infertility. Among these 4 tests, the very, very important test is semen analysis. It's a basic test to be done. Okay, you see, this is semen. So I will not tell the name of the organs here. This semen sample, okay, 60% of the semen sample is contributed by the semen vesicle. The organ which you can see there, it is an internal organ of the male reproductive system. So this organ is called a seminal vesicle. It contributes 60% of the seminal volume. So bulk of the semen is due to the seminal vesicle. So this organ is located behind the urinary bladder. Okay. Now this organ, whatever it secretes, it has high fructose, and when you see the semen sample, it's in a clotted form. It's in a coagulation form. This coagulation is due to this seminal vesicle. Now, secondly, prostate gland. So prostate gland is just below the urinary bladder. This prostate gland contributes 20% of the semen volume. The milky appearance of the semen is because of this prostate gland. This prostate gland has proteolytic enzyme, as well as it has one more enzyme which is very important for the sperm motility. And only less than 5%, even though the testis is the important gonad, okay, of the male reproductive system, less than 5% of the semen volume is contributed by the testis, less than 5%. Whereas rest 10 to 15% of the semen volume is contributed by the other organs. It can be vas deferens, it can be epididymis, it can be bulbourethral gland, it can be the glands which is present along with the penis. Glands which is present along with the penis. Okay. So this is semen. Okay. I have told generally about the semen. Now I have referred only this manual. This manual is easily available in the Google Scholar. What you can do is that you can type 6th edition WHO manual 2021 and PDF. You can download this manual. So nowadays, after this slide, whatever I'm talking, it's from this manual. Okay. Now, once the semen analysis report is generated, okay, what you should focus. So it will be a long 2-page report. You should know what to see in the semen analysis report. So whatever I have highlighted in the red color, you can see that. Okay. You can see the upper red color liquefaction. You can see the appearance, volume, viscosity, pH, and that upper physical examination. That means with the naked eye you are able to see. There is a quantitative examination. Okay, qualitative examination, under microscope you are saying. So you should count the sperm. Okay. And you should see the motility of the sperm. Okay, then you have to see whether there is normal sperms. See, whatever I have highlighted in the yellow color, here the clinicians has to see this precisely and decide the treatment plan. Okay, so these are the yellow color. Whatever I have highlighted, you have to see. This is very important for the clinicians. So rest few things are very important for the embryologists to see. Now, coming on to this, okay, let me discuss briefly about everything. First, liquefaction. Okay, so what semen parameters we should focus on? Okay, so these are the semen parameters. Let me touch briefly one by one. See, liquefaction. So normal liquefaction is around 15 to 30 according to WHO Manual 2021. So once the person ejaculates the semen sample, okay, that clot has to get released. The semen has to be, it should convert into liquid form within 15 to 30 minutes. I can say less than 30 minutes. So from here onwards, you can take down the notes, because a few things if you take down the notes, it will be very easy to answer the questions. In the upcoming slides, I'm going to discuss few case reports. Okay. So less than 30 minutes should be the liquefaction time. Okay, so if it has not liquefied, if the semen has not liquefied, up to 30 minutes is not liquefied. Still you can wait up to 60 minutes. Okay. Still, if it is not liquefied, there is a technique, a mechanical technique, where the embryologist and andrologist will know how to break the clot. Okay, so they will break the clot. Okay, so if there is increased duration for the liquefaction, what happens? Okay, I'll discuss in the upcoming slide. The sperm can be trapped in between this clotted semen sample, and you may give false positive report, like telling that the sperms are immotile, because the sperms are actually trapped. So it is very important to break the clot, and this can happen. The liquefaction time can exceed more than 60 minutes only if there is prostatic gland infection. Now, coming on to the appearance, so normally it should be whitish gray color. Okay, if it is yellow color, you can just assume that the person, along with the semen sample, he has passed urine. Okay, so it will be yellow color. If it is pink, reddish or brown color, it can be hematozoospermia. So this hematozoospermia will happen if the person, so it's very important to take the history. If he is having any blood thinning medications, or if he is having any urinary tract infections, or if he is having any sexually transmitted diseases, or if he is having prostatitis or prostatic cancer, all this can cause hematozoospermia. Hematozoospermia is nothing but you can see the blood in the semen sample. You can see RBCs in the semen sample. Okay. Now coming on to the volume. So volume, we use two terminology: hypospermia, hyperspermia. So according to WHO manual, the volume should be minimally 1.4 ml. Okay. And it can go up to 5.5 ml. It can go up to 5.5 ml, or sometimes it can go to 6.5 ml also. So minimum it should be 1.4 ml. If it is less than 1.4 ml, it is called as hypospermia. If it is more than 5.5 or 6.2 ml, it is called as hyperspermia. Okay. Now, what are the causes for the hypospermia, decreased volume? It can be retrograde ejaculation. Retrograde means what? The sperm is not coming, the semen sample is not coming out to the penis, it is going to the urinary bladder. Okay, it is retrograde ejaculation. And it can be due to the obstruction also. See, where the semen sample is coming out, the anatomy of that is where it's very narrow. Through the narrow space it is coming. Anywhere it can get blocked. So if there is any ejaculatory duct, or it can be an epididymal block also, or it can be a rotative stage block also. So if there is any, wherever there is block, okay, it can cause the semen sample, it won't allow the semen sample to come out. Okay, so when there is block, there will be volume will be very less. It's called as hypospermia. Agenesis means some organs may not be developed, like semen vesicles may not be there. Only sperm will come with very low, one drop. Okay, because the seminal vesicles may be absent, or prostatic gland may be absent, and the seminal vesicle disease also can cause low volume. The hypogonadism also can cause low volume. So low volume, what happens? See, you know that vagina is acidic in nature. Low volume can kill all the sperms in vagina. Okay, and no sperms may enter the cervix, and then later we can go to the fallopian tube and fertilize. So low volume is a problem, a male fertility. You can label him as an infertile. Now coming on the hyperspermia. Hyperspermia, like if the person had a lot of water, okay, or if he has maintained the distance from his wife, means he has not done intercourse for the long time, for more than 1 month or more than 15 days. So this can cause hyperspermia. He can give the volume of the semen will be more than 6.5 ml or 6.2 ml. Okay. Now what happens? Again, hyperspermia is also dangerous. So first of all, in hyperspermia patient, there is something called as DFI. DNA fragmentation will be high. Okay. And secondly, the semen sample, if it is diluted more, the motile sperm, it won't have strength to swim. The acidity of the means the semen sample will be more towards the basic in nature. Okay. Now, coming on to this viscosity. So the normal viscosity means viscosity, right? The thickness of the sperm, thickness of the semen sample. Normally, it will be smooth and watery. The moment we pipette the semen sample, it should fall drop by drop down. Okay, and if it is not falling drop by drop, it is like falling like a thread, which is more than 2 centimeters. It is called highly viscous sample. Okay, so we have some labs has a protocol of grading the viscous sample 2+, 3+, 4+. So based on the protocol, we grade the viscosity. So viscosity, high viscosity will cause decreased motility of the sperm. Okay, see, all are interrelated. So viscosity, again, liquefaction is somewhat similar, I can say. When there is high viscous, there won't be liquefaction. Now coming on to the pH, we term it as increased pH and decreased pH. So decreased pH is acidic pH can be due to this pH should be 7.2 according to WHO manual. Okay, now decreased pH can be due to prostatitis or low semen volume. Okay, and increased pH means basic pH can be due when you pass the urine. Okay, along with the semen sample, it can increase the pH. And what happens if the pH is increased, the natural buffering capacity of the semen sample? It decreases the natural buffering capacity of the semen sample. Now coming on to this very, very important thing, whatever I have discussed, it is, you can see everything under naked eye. Now you have to see under microscope. So for count, these are the terminology we use. So normal count should be more or equal to 16 million per ml. Okay, these are the terminology we use. One is oligospermia, severe oligospermia, cryptospermia, azoospermia, polyospermia. These are terminology we use for count. So now oligospermia means less than 16 million per ml. Severe oligospermia means less than 5 million per ml. And oligospermia means less than 16, above 5. Severe means less than 5, okay, million per ml. Cryptospermia means hidden sperm. Okay, when you put one drop under into the slide and see under the microscope, you are unable to assess. Okay, what you have to see complete semen sample. Then you can find 1 or 2 sperm. This type of sperms are called as cryptospermia. Azoospermia means there is no sperms at all, which is nowadays is a more common cause with the majority of the males. And polyospermia means a lot of sperms. Okay, I can say more than 200 sperms. It's called as polyospermia. So these are the common terminology we use for counting. Now, here let us discuss about azoospermia, because the azoospermia cases, we encounter most of the people, those who walk into the infertility clinic, they are azoospermia patients. So azoospermia means no sperms are present. Step 1, what we do is that we confirm with semen analysis. How to confirm with semen analysis? The patient will give, we have to instruct him. 3 days you have to be with abstinence, and after 3 days you will walk into the lab. He will give his sample. So 2 types of azoospermias are present. One is obstructive azoospermia, non-obstructive. Obstructive azoospermia, these are the picture. Okay, what he will do, he will give 1 drop of semen sample. That is only 0.5 ml of semen sample. And if you check the pH, it will be acidic. Okay, and thirdly, absence of, when you do fructose test, I think you might have done the fructose test, in the biochemistry lab. Same principle applies here. When you do fructose test will be negative, and it will be frothy. Frothy means a lot of bubbles. You can't aspirate that semen sample at all in the pipette. it will be lot of bubbles will form. Okay, so this is an identity. By this you can just assume that the person is having block. Person is normal, but he is having block. He is unable to give the semen sample. Now, non-obstructive azoospermia means everything is clear. Okay, he is giving more than 1.4 ml of ejaculate. Semen sample is there. Color is normal, but sperm is not there. pH is basic. And fructose, no? When you do fructose test is positive, but sperm is not. Say he is giving semen, sperm is not there. It can be. I will be discussing what may be the reasons for this in the upcoming slides. Okay, so azoospermia can be of obstructive and non-obstructive. Now coming on to this motility. So sperm motility, like these are the under these headings we assess the motility: total motility, progressive motility, non-progressive motility, and non-motile sperm. So progressive motility means the sperm, it is very healthy sperm, okay, and it moves in a straight line. I can say linear motion is there. Whereas non-progressive, it is unhealthy sperm. You can say how above 50 years of age person can move. Okay, so like that it won't move straight. Okay, non-progressive sperm. Non-motile sperm, it won't move. If it is moving, there will be some twitching movements at all only in the non-motile sperms. So progressive and non-progressive, when you join together, it will be total motility. So this is 2010. In 2021, they have changed it to rapid progressive, so slow progressive. Some progressive sperms are very fast. Some progressive sperms are slow. So they have classified. Rapid progressive means 25 micron speed per second. Okay, I have written it down. Slow progressive means 5 to 25 micron speed per second. You can say. Now, non-motile means less than 5 micron speed per second. Immotile means there is non-motile means there is no movement at all. Some tail switching is there. Whereas non-progressive means less than 5 micron. Okay. Now, coming on to this, see, there is something called as we do semen analysis with the help of macular chamber. The macular chamber, the cost of macular chamber itself is like it's in highly sophisticated instrument. It will cost around 60,000 rupees. Okay. So usually we do sperm count in the macular chamber or newborn chamber. Newborn chamber, what you see in the physiology lab. Okay, you might have seen this newborn chambers. We do there. We do in that newborn chamber or macular chamber. Whereas the sperm motility should not be done in this two things. It is done in a plain empty slide. Okay, empty slide, we put a drop and we assess the motility. Okay, so you should remember very important this. In 2021, the total motility is more than 42%. When you assess the semen sample, okay, at least 42% sperm should move, total motility. And progressive motility more than 30% or 30%. Okay, minimum 30% has to be there. You see here previous in 10 years back, okay, progressive was 32%. Now they have decreased it for 30%. So at least 30% sperm should have progressive motility. Now, so these are the terminology we use for motility. Asthenospermia. Asthenospermia means less than this previously, less than 42 or less than 30%. Okay, asthenospermia. Oligoasthenospermia means there is decreased count plus there is no motility. Motility is less than the normal range, that 30 and 40 or 42 and 30. Necrospermia means like no sperms are moving. All sperms are like dead it is, but it is alive. Sperms may be sleeping. Like all sperms are not moving at all. I can tell it is dead. Absolute asthenospermia means like sperms are not dead, but it's not moving. Whereas necrospermia means there is a particular percentage of the sperms are dead, means maximum sperms are dead, whereas minimal sperms are alive, necrosospermia. Absolute asthenospermia means all sperm, means maximum sperms are alive, but it is not moving. Okay, occasionally motile sperms means what? Rarely 1 or 2 sperms will be moving here and there. We call it as occasionally motile sperms. So these are terminology we use for sperm motility. Now, coming on to this, now factors affecting the sperm motility. Age. Increase in age, it affects the sperm motility. Concentration, it won't affect. Okay. Some health conditions, long abstinence period. Okay. Excessive heat or excessive cold can cause, decrease in motility. And method of collection. While collecting, if you use soap or any detergent, it can hinder the sperm motility. The adequate handling of the semen sample inside the lab, it can also cause damage to the sperm and it can decrease the sperm motility. Radiation can decrease the sperm motility. Spermicides or pesticides can decrease the sperm motility. And autoimmune disease also can affect the sperm motility. Now, coming on to this morphology. So I've discussed count motility. Now coming on to the morphology. So in morphology, we use this terminology, globosospermia. Globosospermia means, head of the sperm will have two things, mainly two things. One, acrosome and nucleus. Okay, head of the sperm will be having acrosome and nucleus. If acrosome is absent, the acrosome is very, very important for fertilization. Acrosome is very, very important for fertilization. Okay, or I can say zygote formation. So if the acrosome is absent, such type of sperm is labeled as globosospermia. And teratospermia means any head defects, any neck defects. See, sperm has head, neck, and tail, long tail. Okay, in the tail again, we say mid-piece. Okay, we can say mid-piece is there. Okay, you can say head, neck, mid-piece, and very long tail, we say. Okay, any defects in these three parts or two parts in some textbook, head and tail, they say, head and tail. Okay, so if there is defect in the head or tail, then it is considered as teratospermia. And pinnate sperm, it will be like a subtipin. Only tail will be moving, head will be like a one small dot. Okay, so these are the terminology we use for the sperm morphology. Now, coming on to this, now we categorize the sperm morphology under 4 headings. Normal sperm. So normal sperm should be at least 4% or more than 4%. Head defects, neck defects, and tail defects. Okay. These are the defects in the sperm we encounter. Okay, if it is more, then the more normal sperms will decrease. Less than 4%, it is termed as teratospermia. Okay, so for morphology, we usually say it as teratospermia, globosospermia, or pinnate sperm. See here, what the clinicians should do. Clinicians should mainly concentrate on the normal sperm. She should see whether the normal sperms are there or not. So if it is more than 4%, it is considered as normal. It's considered as normal semen sample. Okay. If it is less than 4%, then the treatment is needed. Okay. And whereas other like head defects, neck mid-piece defects, and tail defects. So these are all important for the embryologist while doing some procedure called as 𝐓𝐫𝐢𝐜𝐤 or 𝐓𝐫𝐢𝐜𝐤𝐬 or IMA-AMS. So these are very important factor for embryologist. Now, it's very, very important. The embryologist and the fertility specialist must work hand in hand to discuss the best possible way of the treatment modality, for infertile couples. So both should be hand in hand. Okay. Now, if you can unmute, can you answer these questions to me? See here. The people who are listening, you can unmute. I just post one semen analysis report here. Can you see this? what may be the, what is your interpretation, and can you tell me the plan? So I'll give you 30 seconds, 15 seconds. What is abnormal in this semen report?
Volume.
Very good. Volume. Okay, what will be your plan, madam? What is your plan? How you will treat this patient? Okay, now see here. It is called as hypospermia. Answer is correct. So interpretation is hypospermia. Volume is less. Rest everything is normal. Okay. Now you can plan for IUI, because volume is not enough and all the sperms are killed in due to this vaginal acidity. Better to plan bypass the vagina. Okay. So IUI is planned, and very very important thing. You should ask the patient whether he has any collection issues, or whether he has dropped the semen sample outside the containers while ejaculating. If he has not opened the container and ejaculated, some portion of semen sample might have lost. So you should know that proper history taking is very important. Whether he has lost the semen sample, or whether he has collection issues, whether he has erectile dysfunction, all those things should be noted here. These two here. See here. Can you tell me? Can you analyze this report? Let it be wrong, no issues. Just tell me some
Asthenospermia.
Asthenospermia. Yes.
Viscosity for this.
Asthenospermia. See here. Three things. Viscous is high. Okay. Viscous is high. And this may be due to high viscosity, and total motility is less, progressive motility is less than the normal. Then it is called asthenospermia. Okay. Now, what will be the plan? What can be done for this patient?
Semen processing with IUI.
See here. One thing, if it is highly viscous, since it is highly viscous, we assume it is because of viscosity. Okay. The sample needs to be treated with some proteolytic enzyme, which is commercially available. Mechanical pipetting can be done. And we can plan for IUIs, 2 cycles of IUIs. Okay. Now, case 3, last case. Just see this. There is no motility, no problem, no motility at all, no normal sperms. Okay, concentration is only 2. Means only in the whole semen sample, I was able to find only 2 sperms. What is your interpretation?
Cryptospermia.
Very nice. Yes.
We oligoastenos.
No, it is a cryptospermia. Since I don't have time, I'm just doing it a bit fast. It is cryptospermia. What will be your treatment plan? What will be your treatment plan?
ICSI.
Yes, ICSI. See, first,
An infection.
See, whatever 2 sperms you have got, we can cryopreserve it. Not normal semen sample. Okay, normal freezing is not done. Cryopreservation is done. There is a separate technique called as cryopreservation. Like how we keep 2 embryos, how we freeze the embryos. Similarly, we can freeze the sperms. Okay, one. Secondly, you should counsel the patient that on the day of pickup, on the day of oocyte retrieval, okay, if you are unable to get the sperm, okay, either the patient should be ready for TISA. The patient should be ready for TISA sample. To give TISA sample. If the patient is not ready for TISA sample, we should counsel the patient for oocyte freezing. So all those things needs to be done. So very very important, male infertility evaluation. Okay. Now I just summarize based on the semen analysis report how you can do workup on the patients. Okay. Now, if the semen analysis report is normal, the second line of the investigation will be DFI, DNA fragmentation test. DNA fragmentation is also normal, so no additional workup is needed. Okay, provided his history is proper. Means there is no sexual dysfunction. Okay. Now, if the volume is low, so you should ask the collection problem, or any retrograde ejaculation should be evaluated. Okay. And see how to evaluate retrograde ejaculation. Immediately you should tell the patient to pass the urine. See analyze the urine. They immediately centrifuge that urine in high speed. Analyze the palate. Okay. This second one, volume. Now, if there is decreased sperm count, what you should do? You should do some physical examination of the reproductive organ. Second, you should do scrotal USG, FSH, hormonal evaluation has to be done. FSH, testosterone, LH. and abnormal sperms. Lot of abnormal sperms are there. Only hardly 1% or 0% normal sperms are there. Means no sperms, no normal sperms, or 1% normal sperms. So you should evaluate such a patient for genetic cause, and you should better to refer that patient for the uro-andrologist, okay, to rule out the varicocele, and you should ask the proper occupation. That proper history taking is very important. What occupation is doing, all those things is very, very important. So this is general workup on the semen analysis. See, we have done all this history taking, physical examination we have done semen analysis. Now coming on to the hormonal profile. So you might have learned in physiology. See, hypothalamus stimulates the pituitary gland, okay, and the pituitary gland will secrete FSH. FSH will stimulate the Sertoli cells present in the testes. Sertoli cells, is responsible. It will cause. It is an important cell which can cause spermatogenesis. Now, spermatogenesis, what happens? The Sertoli cells will also stimulate also secrete the inhibin. Firstly, it causes spermatogenesis, okay, and it will secrete the inhibin. This inhibin secreted by the Sertoli cells, it will tell the pituitary gland to reduce the FSH secretion. Okay, so this is a normal physiology we usually study in the physiology textbook. Now, see, on the other hand, pituitary gland will also secrete LH, okay, luteinizing hormone. Then it can stimulate the Leydig cells, and the Leydig cells will secrete testosterone. Okay, and testosterone itself has a negative feedback over the pituitary gland. Now, so this is a normal physiology. Okay, now let us study first scenario. In the first scenario, everything is normal. See, FSH is normal, inhibin is normal, testosterone is normal. You can see, right? I have highlighted FSH normal, inhibin normal, testosterone normal. Everything is normal, but the patient is not able to give the semen sample. Okay, is azoospermia. Then the condition is obstructive azoospermia. Okay, now for this, what is the treatment? TSA, PESA, TSA, MESA. Okay, full form. TSA means testicular sperm aspiration. Directly inject to the testis, remove the sperm. PESA means inject to the epididymis, remove the sperm. Okay. TSA means, see, in TSA and PESA we are unable to get the sperm. We remove the tissue, means we remove some seminiferous tissue from the testis, and we tease it under the microscope and hunt for the sperm. MESA means under the microscope we open the testis completely, open the scrotum, approach the epididymis, see under the microscope, and aspirate the sperms. So it's MESA. So these are the treatment given for obstructive azoospermia. Okay. Now, second scenario, FSH is very high, inhibin is low, testosterone is low. What may be the condition, doctors? Can you tell me? What may be the condition? FSH is very high.
Testicular failure.
Very nice. Gonadal failure. So you have to examine the testes. Whether it is shrunken or normal size, you have to send the patient for karyotyping to rule out the Klinefelter syndrome, or to see whether there is any Y chromosome microdeletions, all those things. Okay. Now, in third scenario, everything is decreased. FSH decreased, inhibin is decreased, testosterone is decreased. What will be the condition here?
Pituitary failure.
Very good. So it is hardly 1 or 2%. We are seeing hardly 1 or 2% of the patients. Okay. So there is a problem, an issue in hypothalamus or pituitary gland. So screening for endocrinopathies and CT scan is very, very important here, and it can be treated to some extent. Now, one semen analysis report. Okay. Azoospermia. Azoospermia means what? There is no sperm. Low volume, major portion of the sperm is lost, acidic, okay, absence of fructose. So this is a scenario. Okay. Now, what you should do? It can be of three. You can assume it may be due to these 3 reasons. either patient may be having a retrograde ejaculation or obstruction or absence of vas difference or seminal vessel. Okay, these three things can be assumed. Now, first you should do physical examination. Not able to palpate the vas difference, then it is absence. Absence of you should try to palpate the vas difference or seminal vesicle. Epididymis or vas difference. If you are unable to palpate, then there is a congenital problem. If you are able to palpate, then you have to send the patient for ultrasound. In ultrasound, the seminal vesicle, if it is dilated, that means after that there is a block. Okay. Now, and if the seminal vesicle is absent in ultrasound, then there is a congenital absence of vas difference. Okay. And if both are normal, there is no dilated, okay, there is no absence of this vas difference, and the hormonal profile is normal, then the sample which is supposed to come out to the penis is going to the urinary bladder. Okay. Now, what are the ART procedures? What we follow? Usually, commonly done in all the embryology labs or in infertility center. See, first, mainly these ART procedures. Whatever do in the embryology lab, it's mainly to rule out the male fertility. Okay. When there is a severe male factor, we go for this ART procedure. One like conditions like mild asthenospermia, mild teratospermia, and mild decrease in the sperm count. Okay, I can say above 5, below 16. Okay, we go for IUI. Okay, so IUI, this again is a separate topic. How to prepare the seminal sample? We usually prepare by Sum-Up method and density gradient. It has its own protocols to prepare. Okay. So finally prepared sample, if it is having more than 10 million per ml and morphology is 4%, the best results can be achieved through IUI. Okay. So this is a density gradient method. Okay. Now, indications for IUI and IVF. Now, see here. For IUI, mild male factor. Okay. Retrograde ejaculation. Sexual dysfunction, okay, like impotence and ejaculatory dysfunction, and unexplained infertility. So these are the reasons for IUI. You can try up to 4 to 5 cycles of IUI. Okay, and when you have to post the patient for IVF, okay, tubal factor, mainly tubal factor, means there is no fallopian tubes. You have to post it. And here severe male factors, okay, like less than 5 million sperm count is present. Now absolute asthenospermia. So all those when there is severe sperm motility problem are there, we have to post them to IVF. And treatment failure. Like now, you have told the patient for OI plus IUI, they have tried for 3 to 6 months. Okay, and if the patient is having PCOS, better to recruit them for IVF. Unexplained infertility. Okay, still you can try with 3 to 6 months of normal intercourse. They will try to conceive. If they are unable to conceive, even after 6 months, they have to be recruited for IVF. So that's all about and very, very important, like pre-implantation genetic, like if they are having any genetic causes, okay, it's better to test the embryos and transfer the normal embryos. So that's all about today's discussion. If you have any questions, please ask me.
Like hormones, what all we are supposed to do it, sir? Like hormones, FSH and inhibin and LH. Is it necessary that?
Dr. Inhibin is not required. FSH.
Okay.
FSH will give a clear-cut idea. Okay.
Okay.
It required testosterone. Okay.
Okay, sir. Thank you, sir.
Usually with the FSH, no, you can assume what has happened.
Thank you, sir. Okay.
Thank you.
So we have a small quiz right now. So dear students, you'll be able to see the questions on your device. So you'll have 4 options and you'll have 30 seconds to answer each question. I would request you all to select the answers quickly and so that we definitely get back to what is the right answer. So starting with the first question for the day. So the first question is, IUI should be cancelled if greater than 4 follicles.
So first one is the correct question answer. And next question.
Second question is, parameters of receptive endometrium, A triple layer, endo thickness of 8 to 10 mm, mean UT artery between 2 to 3, option D, all of the above.
Option D is the correct answer.
Option D is the correct answer. Moving ahead with next question. Indication for double IUI. The options are A, male factor. Option B, if no ovulation after 36 hours of trigger. Option C, donor IUI. Or option D, all of the above. So the option is D, all of the above. Up next we have the fourth question. Which is not a proper technique for technique of IUI? Option A, full bladder. Option B, USG guided. Option C, cleaning with betadine. Option D, not touch fundus. So the correct answer is option D, no touch fundus. Now with the fifth question. Which of the following indicates a mature follicle? Your options are A, internal echoes. B, thick walls. C, color flow present around 75% of the follicle. Option D, follicle of 15 mm. Dear doctors, the correct option is option D, follicle of 15 mm.
So how many sperm analyses are needed to confirm fertility? So according to the World Health Organization, minimum 2 samples you have to take. Minimum 2 samples to confirm the semen analysis. Okay. And to recheck, see first, for example, first sample is given and you are unable to see the sperm, you want to analyze second sample. What you can do is that you can take 2 weeks gap. Okay, that is 2 weeks gap. So here to confirm, okay, some abnormalities which is present, at least 2 samples are needed. Next question. So second one is the correct answer, 2 to 4 weeks as per the WHO. Okay. So next question. Patient history, a physical exam, and what else useful for diagnosing infertility? So majority of ticked both hormonal assessment and semen analysis. Both are right. Okay, both are right. Okay, hormonal assessment as well as semen analysis is very important, and among these two, very important if you want to select, it is semen analysis. In non-obstructive azoospermia, so first one is proper. Non-obstructive azoospermia, fructose will be present. Okay, there is no blockage, right? So fructose will be thrown out by semen vesicle. So fructose will be present. First one is a proper answer. Like a fructose test is positive. So next question. Okay, 10th question. Collect after a dash of sexual abstinence. Say when to collect the semen sample. What should the abstinence? So can anyone unmute and tell me 48 to 168 hours means how many days? 48 to 160 hours.
3 to 7 days.
Huh? 3 to?
3 days. 7 to 7 days.
Yes. Okay. So first one is correct answer, 48 to 168 hours. Okay.
You can definitely unmute yourselves and ask. We just have one option for last question for the day.
How much time we can wait? On which day of cycle now we should wait? We should stop to wait. So the follicle is not rising the cycle that 18 mm, 16 mm. How much time we can wait?
It depends on the hormonal assessment.
Yeah, hormones. I mean, say, can we proceed after 18th day of cycle?
What?
Can we proceed after the 18th day, even if the are we expecting that the follicle will mature even after the 18th day of cycle or 16th day of cycle?
Yes, you can proceed. And very important to see, everything is interrelated. Hormonal assessment, scan. Okay. So
the follicle is growing now. Now I'm expecting the follicle is growing. Say, but can I continue my cycle till 18? Can I give the trigger after the 18th day of even?
Yes, you can.